So this is my official welcome and good afternoon to all of you, and thank you for joining us today for E-QIP's or the Excellence Through Quality Improvement Project's Data Literacy webinar, Unlock the Power of Data webinar series. And this session is titled Collecting and Using Data to Drive Equity Plans, and we're very happy to have you join us. We would like to begin today's webinar with a land acknowledgement that will be delivered by Shireen Ramprasad.
Thank you so much, Laura. Let me just get started. So we're gathered today from many parts of what's now called Ontario, but has always been Turtle Island. I'd like to begin by acknowledging the land on which I have the privilege of living and working, which provides me the space to play. Peel Region is part of the treaty lands and territory of the Mississaugas of the Credit. In particular, I acknowledge the territory of the Anishinaabe, Huron-Wendat, Haudenosaunee, Neutral, and Ojibwe Chippewa peoples, the land that is home to the Métis, and most recently, the territory of the Mississaugas of the Credit First Nation. I'm grateful to have the opportunity to live on this land, and by doing so, I give my respects to its first inhabitants. I acknowledge that the legacy of residential schools and colonialism continue to negatively impact Indigenous communities today. I commit to hearing the stories of this country's First Peoples, to educating myself about this country's history with First Nation, Inuit, and Métis people, and to incorporate my learning into my practice and my principles. I seek a position of cultural humility in which I might engage meaningfully with First Nation, Inuit, and Métis colleagues in the interest of Indigenous clients and their families, caregivers, and communities. I encourage us all to put into action the 94 calls to action from the Truth and Reconciliation Commission of Canada by recognizing the attempted genocide of Indigenous peoples in Canada, which spans centuries and continues today. I recognize the privilege that I hold as a settler in this country. As such, I commit to heeding the calls to action through my advocacy, active voice, and action in my workplace, my community, and my everyday life. As a person of color, I am honored to share space with the Indigenous community in our commitment to dismantle racism and oppression for all equity-deserving peoples. We stand in solidarity and recognize that the calls to action help provide a solid framework of reconciliation for the injustices that have been carried out against Indigenous communities, including broken treaty relationships, the trauma of the residential schools, the continued attempts by government at all levels and religious groups to control the Indigenous family unit, resources, and access to services. With the recent passing of the Honorable Murray Sinclair, I end with his words. When he was asked if reconciliation is possible, he said, in fact, reconciliation is inevitable. We must never forget. N'oubliez jamais. Thank you. Merci. Miigwech.
Thank you very much, Shireen. So as we settle into this session, thought I would just kind of ground us in the purpose and the objectives. And I'll first start with introducing myself. My name is Laura Daly-Trottier. My pronouns are she, her, and I am a QI and data coach for the Excellence Through Quality Improvement Project. I've had the distinct pleasure of facilitating these data literacy conversations over the last 3 years. And to date, we have delivered 10 webinars and 3 workshops, all aimed at supporting the sector in understanding and using data for planning and delivery of the mental health and addiction services in this province. Our mission is to make data the realm of everyone and to turn data into the beginning of a conversation. So in this webinar, participants are we're hoping that you'll leave here with some knowledge about why data collection is essential for advancing equity initiatives by first understanding that foundational concept of equity, including definitions and some historical inequities. We'll discuss how data is crucial for developing actionable equity plans, identifying disparities and setting measurable goals and tracking progress. And additionally, we'll explore key data types and sources, highlighting both qualitative and quantitative methods for collecting staff and client data. And then we'll finally touch at the end of our presentation on how to foster data equity culture within organizations to ensure that data practices are inclusive and reflect the diverse needs of the communities we serve. And for those of you who are joining us for the first time, this slide came from the very first webinar in this series, where we had Dr. Derek Chichak kicked us off with our Data Literacy 101. And we've continued to use this slide in subsequent presentations to help ground us in answering that question, which is why data literacy? And the underlying theme of these webinars is that data literacy is increasingly pivotal in a rapidly evolving digital landscape in an era dominated by information, where it's easy to find and often be overwhelmed by the amount of data and data sources. Understanding how to navigate, interpret, and harness information is just not a skill, but it is a necessity. So think of data literacy as a critical skill, a practical resource, and a communication tool. And as such, the basic concepts that are needed to interpret this language becomes increasingly important. Data informs local and regional planning, system efficiency, and measurement-based care. Examples of the use of data include Ontario Health Team dashboards, the OSP reporting tools, OCAN reports, and as a sector, we are fast implementing the PDS, and more agencies are mining their own data to better understand who they serve and how. The increasing focus on progress and outcome monitoring on measurement-based care require accurate data to demonstrate performance at the client and at the organizational level. And in many ways, we have an opportunity to think better than what was built for other sectors, and we can focus our measurement on what matters to our clients. So we're building on a culture, and in a culture that embraces quality improvement and accountability, data are used to monitor performance, track changes before and after an intervention is implemented, and are transparently shared with boards of directors, funders, and the public. Data literacy skills allow us to create outputs from these data like tables, charts, and graphs, but also understand outputs created by others. It helps us understand where the data originated, how it was collected, and how it was analyzed and visualized. Data is power, and in some cases, that power has been used in a harmful and an inequitable way. And we hope that this webinar, somewhat different from others we have offered, will highlight how this harm has impacted. And we are so thankful that we have a subject matter expert joining us today. So without further ado, I would like to introduce everybody to our presenter today. Her name is Shireen Ramprasad. Her pronouns are she, her, and Shireen is the Equity, Diversity, and Inclusion Manager at Services and Housing in the province, SHIP. She has worked with SHIP for over 17 years in many areas of the organization, but as the EDI manager since May of 2022. Shireen is a social worker who has spent her career working with diverse populations within the mental health addictions and supporting housing field. And Shireen is a community leader and staunch advocate for enhanced access and services within the community that meet the needs of the people whom she serves. So I will pass the presentation now over to Shireen. I'll just advance it one slide, Shireen, if that's okay.
Thank you, Laura. Thank you so much for having me and allowing me the space to talk about something that's very important, I think, to not just our communities, but also to our organizations who are advocates for the best possible care that we can provide for the people that we serve. So I'll get us started by letting you know a little bit about the organization that I work for. SHIP, or Services and Housing in the province, is a nonprofit. We're an accredited organization that is a housing and health service provider. We've been around for over 30 years, and we've been delivering services to the region of Peel primarily during that time, also the County of Dufferin, West Toronto, and most recently, we have ventured into the region of Waterloo. We promote the well-being of vulnerable and at-risk populations, and we work closely with individuals in the community, enabling them to embrace their full potential. Our mission is to work to support those with mental health and addictions challenges to increase their quality of life and live to their full potential through safe, affordable, community-based housing and services. Our vision is quality housing, quality services equals quality lives. And our values are CHIRP. We love acronyms. So compassion, hope, inclusion, respect, and professionalism. And I just want to note, we were last year's Charity Village Best Nonprofit Employer for Diversity, Equity, and Inclusion for employers of 20 plus staff. So we're very proud of that because of the work that we have been doing in this EDI space for the past few years. And you're going to see some of that today in some of the examples that I give. And all of the examples and all of the things that I share are things that we are endeavoring to do at SHIP. And I say endeavoring because we are on this data equity journey also. We certainly have made wonderful progress, as I hope you will see from our presentation today. But certainly it is a journey, and we value that. And it helps to be recognized because then it provides a voice for some of the areas that are sometimes challenging for folks to talk about in our space. And then finally, our strengths, and we firmly believe that our people are our greatest strength. The folks who work and provide services at SHIP are the strength of the organization. And secondly, we look at our housing, and I am a staunch advocate for the idea that housing and having a safe place to call home is one of the most important social determinants of health. And I think we'll talk a little bit about that in the presentation as well, but we are a supportive housing provider primarily. And then certainly all of the services that we surround our housing with are equally as important. And those are our greatest strengths. And we have had the opportunity to really contribute to community and share some of the things that we do at SHIP that we believe are promising practices that should be shared with other communities and other people in the community who are service providers so that they may continue to learn as well. So we're going to start. And when we talk about data equity, we have to understand what equity is to begin with. We have to firmly understand what we think of as equity and therefore have an understanding of where inequities lie. And that brings us to understanding the why. Why do we even collect data? Why do we ask questions? Why are we the big why? And I put it in capitals on purpose. There's many different whys, and there's many different ways to answer the why question of why organizations collect data and information about your clients, about the community, and about your organization itself. But in order to understand the why, you have to understand the equity piece of it, and that's why I'm here today. So I'll come back to the we ask because we matter in just a bit. Let's start with a video that will establish very simply for us, I hope, the answer of what is equity.
Sorry, the audio not working, but I'll restart.
I've come to think that most people believe that everyone deserves the same opportunity to achieve good health. That we should all have what's necessary to pull ourselves up by our bootstraps. That we should all be given boots that fit. And that's when I learned the difference between equality and equity. See, one ensures everybody gets the same thing while the other ensures everybody gets the something they need. Take 3 neighborhoods. Each one is situated across from the grocery store. One has no transportation system and the streets aren't safe at night. One needs a boat to get there, and one is positioned a block away. Equality says we hand them all boots and tell them to make do. One size fits all solutions for problems that require more than one resolution. But equity, the quality of being fair and impartial, speaks to access. Equity speaks to safety. Equity speaks to transportation. Equity speaks to understanding. Equity speaks to the actual human condition.
So the reason I like that video is because it really simplifies what we talk about when we talk about equity. It just gives us that firm understanding of the difference between equality, which most of us are familiar with, and equity. Let's take it one step further, though. Let's talk justice, because that's really what organizations like ourselves, service providers for community, are seeking. So inequality, and I love this diagram, the way that it's depicted. It's kind of reminiscent, and it brings me back to my childhood. And for many of you, probably the same. It's reminiscent of the Giving Tree. It's a childhood book that, but I would argue not necessarily just for childhood. I still have it for myself, and I still look at it from time to time. But the diagrams are from that book, The Giving Tree. But what it really exemplifies for us is the pathway and the journey towards justice that we all take. So we start with inequality, and you'll see in the diagram, we have two people, and there's the Giving Tree, which has apples that it wants to give to people. It certainly wants to give to people. Oh, can we go back? Sorry. And then in the first one, inequality, the person on the left has access to the apples. The tree is leaning towards the left. There are more apples available towards the left, and that person is able to access the apples without even doing anything. So the tree, if we think of the tree as the system, the tree is us, is just giving to that person on the left without anybody having to do anything, because the system is predisposed to giving to the person on the left. That's inequality. Then we go towards equality, where we don't have to do anything either. People, so the two people have gotten ladders. So instead of the system changing, people have done themselves, provided their own opportunity to access the apples. So they both have ladders. They both have the same thing. Equality says that people have the same thing in order to access the same thing. So inequality, both of them have ladders, but we see the person on the right still does not have access to the apples. When we move towards equity, we make steps to say, we're going to give people what they need to access the apples on the tree. So now, even though they both have ladders, the person on the right has the bigger ladder so that they are able to access. But what do we notice about the tree itself? The access that the person on the right has is less than the person on the left, because there are less apples, on the right, because the tree is still leaning towards the left. That's equity though, right? So we could stop there. We could stop at equity, because equity says we have provided what people need according to how they need it in order for them to have access to us, the tree. But really, I think for most of us, for our organizations, and for yourselves as folks working in helping fields, what we really are seeking is justice. Justice requires reconciliation. Justice requires reparation. Justice requires that we move from equity to change ourselves. That's where the system piece comes in, the system transformation piece. We take the steps towards equity, building equity into our practices, into our organizations, in order to achieve justice for people, to build a just culture and a just society. And that means that we change ourselves. We dismantle the broken system. So we dismantle the tree, and we make the tree work for the people that it serves. So our system being the tree, and you see in the final diagram of justice, our tree is now straight. Our tree has apples all over the tree, available to everyone, no matter where you are accessing it from, whatever point of the tree that you want to access the apples from, you have access. So we fix the tree in order to find justice. So we fix the system in order to provide a just culture for people and just access for people. That requires then the acknowledgement that inequities exist within our system to begin with, that our system is inequitable to start. And so the work part of it that organizations do to achieve justice is going back to that equity piece. That's where the work lies. The work lies in building equity into practice, into into how your organizational functions and provide services so that we can achieve justice. The work doesn't come at the justice piece. The justice is what we deliver. The work is the equity piece. And that's why we're talking about data equity today. So we have a poll, and you'll see a lot of polls. I like to be interactive. I like to hear from you as well during these. So our first poll is, which of the following historical studies are you familiar with? Select all that apply. So the first is the Tuskegee syphilis study. Then we have Sims gynecological research. We have Henrietta Lacks, and we have the 60s scoop. Just give it a couple of seconds. And if you're not familiar, that's okay too. That's why we're here today. We're here today for you to become familiar with some of these things. All right, so a lot of familiarity with the 60s scoop, which understandably, the 60s scoop is very Canadian. The other studies are American-based studies for you to understand. So generally, I wasn't expecting very many people necessarily to be familiar with them, but there is some familiarity as well. So folks have heard about some of these studies at some point in time. You've heard about them in some way, which is great, because what we're going to talk about now, if you want to stop sharing, Madeline. Can I move forward? Okay. So I'm going to give you some context. These studies are all historical studies that provide some context about data inequity, how data has been used to perpetuate oppression, to perpetuate systemic discriminations, to perpetuate stereotypes, and to create inequities in our systems, primarily from the healthcare system perspective. Most of you said you were familiar with the 60s scoop, which is very Canadian. And I have provided some references and resources at the end of the deck for you all. So you can also read some of these studies yourselves if you're interested. But certainly the 60s scoop, when we look back and we look at what happened there, the idea that Western science was a tool to justify and sustain the processes of colonization, and was able to, we use data collection through government agencies to be able to justify racist policies and subjugation, in order to be able to extract children from their families in the residential school systems, in the 60s scoop. So the 60s scoop and the policies and the processes that were a part of that justification of removing children from their homes was anchored in data. They provide data, they collected data, not well and not good data, but they did. They collected data and they said, this data shows, this is evidence that we have reason to remove children from their families and put them into the residential school system in order to improve their quality of life. Sound familiar? Does it sound familiar when I say improve quality of life? Because that's what we all do. We have it in our values, quality lives. So even that language, right? The idea that evidence-based practice is what they said they had in order to remove those children during the 60s scoop. And then we moved to the Tuskegee syphilis study. And I think there were quite a few people in the poll that were familiar with this. And generally, I think in healthcare, this is a familiar sort of study that, especially during COVID, that people referred back to when we were looking at sort of that vaccine hesitancy in the Black community. In the Tuskegee syphilis studies, Black men were, brought into the study under false pretenses. And they were given different levels of treatment. And what they were doing is that they told these men that they were being treated for syphilis, which was a lie. And then they prevented the participants from actually seeking treatment that could save their lives after the study was completed. And the study was primarily Black men. So there was embedded within the study principles inequities to begin with. And then in the follow-up pieces, when things started to come out about the study and people started to question it, they covered up their lies with data. with data. They provided evidence to cover up the lies that they had told the participants. And then Sims gynecological research, which was something that in the poll, not very many folks were familiar with. And I won't get into too much detail. And like I said, I have the references for you. The Sims is best known for having invented and created some of the gynecological tools like forceps and things like that that are still used today, and some of the gynecological principles and procedures that are still used to this day. So he is credited with having created those and invented those tools. However, Sims' research was conducted on enslaved Black women without anesthesia, without medical ethics, and they were the subject of torture. In a lot of the research that you will read, or a lot of the articles that have been written, he basically tortured these enslaved Black women in order to be able to conduct these medical tests and create these procedures and these tools. And then Henrietta Lacks was a Black woman. She had a very rare disorder. Her cells were collected at one of the hospitals where that would provide care to Black people. And her cells were unique, and they have become the sort of basis and foundation for many of the medical treatments that we have today. But the companies and the biotechnology that they created based on her cells, they kept to themselves. And this was in the States, and they never compensated her family. They never compensated her, and they never received her consent for doing what they did with her cells and for creating all the pharmaceuticals that came from her cells. They have never received her consent. And they also released her name publicly, gave her medical records to the media without her consent or her family's consent. So that there too shows sort of the inequities that existed and still to this day exist in the medical system, in our healthcare systems. So why do I tell you this, and why do I start here? It is because we have still in practice situations and tools that we use and ways of collecting data with particular communities where there is a mistrust that exists. And that mistrust lies in has historical context. And so I also have provided some references around scientific racism, which is a study in and of itself, in a field in and of itself. But one of the ways in which we can view scientific racism is through some of the studies that I just cited. It's been used as one of the ways in which we can justify anti-Black racism and white supremacy within the healthcare system. It's taken many forms, but the goal is to really use science to prove that there are inequities that exist based on race. And so over the years, the healthcare systems and our colonized systems were really based on these principles that come from a very racist scientific approach. And I put colonization here because this is the basic foundation in Canada of everything and every system that we have in place today. The reason that I cite the seventh generation principle and intergenerational trauma is because when you look at the indigenous concept of the seventh generation, of 7 generations, where trauma and experience last 7 generations. So there's that historical memory that we all have, passed down in stories, passed down in experiences, passed down in how we raise our children. Even though the folks today, your clients, your patients today, may not have this historical context themselves, what they have is the trauma experience of that experience that folks have from the Black community, from the Indigenous community, from our 2S LGBTQ plus communities, with the healthcare system and with systems that has bred mistrust of our systems and therefore mistrust of data collection. So when we look at how we collect data and when we look at the data that we are asking from people, which is mostly socio-demographic data, we also have to understand that many communities have had data used against them, have had data used to perpetuate inequities, perpetuate these systems of oppression that exist for them. And therefore, why would they trust our system? And why would they trust us who are asking these questions and collecting this data? So that's why I talk about the historical context, because the tools that we use today and the ways in which we collect data today are very similar to what people did back in the day as well. So we have to really put into perspective what you think, how you think that people, when you're collecting information from them, how you think they view you and what you're going to do with their information. Next poll. So big why. Why do you collect client demographic data? What is the big why for you as an organization, as a person who is providing a service? So you can select all the apply here again. Reporting requirements, because we have to, quality improvement planning, service planning, individualized case planning, building inclusive practices for client service. Awesome. Awesome. As I expected, right? I think as we all can expect, we all collect data for all of these reasons. These reasons pertain to all of us, and especially number one, right? We have to. We have to do it. And everybody knows we have to. We all know that we have to collect data. It's requirements, usually from our funders, requirements from our, organizations, whoever you report to, required to report on data. So for all of us, these can all pertain in different ways as your organization does its work. So therefore, it's really important if we look at the reasons why we collect data, the importance is there on why we tell people that we collect data and what we do with that data. One of the things that we do, and I'll talk a little bit about it in a bit, is a training program for our staff around collection and application of inclusive data and how we do that from an equity perspective. And one of the things we go through in that training is why it matters. So I promised you I'd go back to the title of We Ask Because You Matter, that I titled this section, and explain that a little bit. Several years ago, I think the Ministry of Health, or now the OHTs or the OHs, we had a campaign when we started to collect some of this demographic data from clients, really driven by the hospital system. And it was only a few questions for those of you that remember. It wasn't the breadth of data that we do now with PDS, but it was a few questions where we're starting to collect some of the socio-demographic data. And there was this campaign around We Ask Because We Care. Hands up if you remember that. We ask because we care. And I think it's still around, but at SHIP, we've changed it. We've changed that perspective a bit. Yeah. So folks, you might remember, we ask because we care. And they sent out a bunch of information, and there was I call it a campaign because it really was a campaign to sort of standardize processes, standardize language, standardize the way that we talk about the questions that we were asking, which were about gender and about income and things like that. So we did that at SHIP too. We were part of that campaign. We certainly, did that. We had to report on it. So we did do that. But over the years, we have really moved and shifted our culture when it comes to that type of data. And We Ask Because We Care became a barrier for us to be able to build relationship with clients. When you say we ask because we care, is it really because we care? Like, isn't it a given that we care? Don't your clients already know? Patients know. They wouldn't be coming and seeking services from you if they didn't think you cared. So you're really just restating the obvious. And that's not the actual reason why we're asking them those questions. It's not because we care. That's a given. So we've moved to we ask because you matter. When you say we ask because we care, that's about us. That's only about us. We're saying we ask because we care. Where's the client? Where's the person in that statement, in that explanation of why? Because that was supposed to be the explanation of why we collect data, why we're asking the question, is because we care. Is that enough of an explanation for you to tell somebody your personal information? Especially now, you think back now to what we just talked about, which was the tools of inequity and the historical context of why folks do not trust systems, why folks do not trust data collection methods. So we've shifted to we ask because you matter. And that is the real reason why we ask these questions, because people matter. Getting to know people and who they are and what their needs are that are unique to them, that matters. And it's because of the person that we're asking the question. So that's why I titled it, We Ask Because You Matter. That is the subtle shift that we have made around our data collection of sociodemographic data for clients. It helps us to connect and align the unique needs of our clients based on their identity. It enables us to provide services that are tailored to to meet those needs. That's the why. That's the why. That's what we tell clients, because that is the why. The goal of collecting sociodemographic data is to improve care in a broader scope. This data can be a powerful tool in dismantling systemic barriers that exist for clients within our services. That's the why. That's what we tell clients. That is the big why. The big WY is that we use this data, hopefully, to try to dismantle the barriers that exist that we inadvertently and unintentionally are providing for you. So the big why lies in why do you actually collect the data and what do you do with it to improve quality services for people? We also use your data to identify inequities, develop policies and practices to speak to those inequities. We monitor and evaluate our interventions. We hold ourselves accountable for improving outcomes, and we intend to facilitate system-level changes. This data can be used to inform prevention, intervention, and strategies to protect human rights. So when we do our training, this is what we tell staff. This is SHIP. As an organization, this is what we do with people's data. And this is what your conversation with clients is when they ask you why, or even before they ask you why, because they shouldn't have to ask why you're collecting the data. You should be offering that information. Okay, so I'm going to talk, I just started to talk about the training process that we have at SHIP. So we're going to move from the why, and hopefully we've established a little bit of the why piece for folks, why we collect data at SHIP. Now we're going to talk a little bit about the how. And I mentioned that we have a data equity training program that we developed internally within the organization. And what that means is that we developed a training that is required training for all direct and support service staff within the organization. So all of the direct staff are required to take this training. It is a training that reviews the technical aspects of data collection, so our CRMS system, our client record management system, and how to use that and how to use that effectively. We link demographics data to social determinants of health. So we talk a lot about what the data actually means and what that information that you're asking clients, how that impacts your job, how that impacts the people that we serve. And then we discuss the why of data collection and what we do with the information, which were the last two slides that I just went through. So we have that embedded into our training program at SHIP. And then finally, in the training, we discuss the how. And that comes down to asking questions versus making an offer. And so we have reframed the idea of asking demographic questions and collecting data to we're not actually asking questions, we're making an offer. Before you ask a question about somebody's gender, offer the space for them to tell you. Create safe spaces for clients for them to offer the information to you. And that requires work on our part because it's a shift in the culture of how we do things. We're very used to having checklists and saying, this is an assessment. I'm going to ask you some questions, and you can tell me as much or as little as you want to. But we do it in this way that is always asking of a client or asking of another person. In our training, what we do is we shift that to make the offer first. When you're requesting information, if you term it in the way of an offer, do you mind telling me a little about yourself? Where you come from? What do you need from us? Do you mind telling me how you identify? Let's talk about that, instead of it being, I have to ask you about your gender. I'm going to ask you about your ethnicity. We talk about this in our training with staff, and we get down to what are the uncomfortabilities that lie for you when it comes to collecting this information. And the way that staff have explained to us why they're hesitant, or why sometimes they don't answer the question or ask the questions to begin with, is because of these things. So in our training, we discuss the idea that I always share a little bit in the training. I do this part of the training. And what I say is that I think of myself when I go to the hospital or when I go to a service provider and they're asking me these questions, how comfortable am I with answering them, depending on the way that I'm approached and depending on the person asking the questions. And so if we think of how we as service users feel when we are asked these types of questions, and then think about how can I change that? What would I like to see from the person asking me the questions? What would make me more comfortable to answer those questions for that person myself? It would be a conversation. It would be a conversation, an approach that is more about an offer and a space to say no and a space to say I'm not comfortable, and build on that. The other thing we do in our training is we really remove the pressure for staff, because there's no time frame on getting to know someone. There's no time frame on getting to know what your clients, who your clients are, or what they need. So there are time frames on collecting data. When we frame it that way, yes, people feel pressure to collect data and put it in the system. But when we look at it as being offer space to clients to answer questions about themselves or to tell you about themselves, and then you're doing that anyways. You're doing that anyways. So put the information into CRMS as you're having these conversations, as they're letting you know about themselves, you just put the information into CRMS. So it provides a greater opportunity for staff to do what they're most comfortable with, instead of feeling that pressure of doing what's a part of their job. We all know it's a part of our job. Everyone, including the clients, know that it's a part of your job. So put it out there. Put it out there. Make the offer and really, relax the conversation a bit. Get to know the person that you're working with. So this should be familiar. We've just put it in a nice, lovely diagram for folks. This is the provincial data set, PDS, that most of us, if we're funded by the Ministry of Health and Mental Health and Addictions programs, this is all the data that we have to collect. This is all the information that PDS has that we have to collect. It's a lot. When you put it like this, it's a lot. It's a lot of information. So imagine if you have a checklist in mind and you're going to a client and you're saying, I got to do this. I got to ask you all these questions. How overwhelming is that for everyone involved? And then when if it's a new client and you're doing an intake and you're trying to collect this data for someone who doesn't know you, doesn't trust us yet, and that we don't know at all, that's even more uncomfortable for folks. So what we do in our training is we link PDS to the social determinants of health, because that is essentially what they are. These are the social determinants of health. And so the reasons why we want to know this information is because we're a healthcare provider. We want to improve health outcomes for folks. So that's what we do in the way that we view PDS information. And I will say at SHIP, we do collect all of this PDS information. I'm going to show you just in a second. So I'm going to start you off in how we collect PDS. We've developed dashboards, and you've seen, if you've attended some of the other webinars, that a lot of people have, dashboards now. It simplifies, it makes things much easier to see. It makes the data that you have about people a little bit easier for you to see whether or not it's significant. It also enables you to see, a dashboard enables you to see whether your data is aligned and whether it's valid, because you can see, and that's what this shows right here. This is our original dashboard that we started back in the CDS days, so the common data set before we became PDS. So there were far fewer data items that we were collecting, sociodemographics that we were collecting back in the CDS days. But that's when we started our dashboard, is when we were collecting CDS. And we had a training, the training that I just talked about, we had that training, we developed that training for the collection of CDS. And we had this dashboard. And so when we first started with that data equity project, we were at 54% alignment. And we call it alignment. We don't call it compliance, because compliance just, it makes it feel like it's you have to, and we're not compliant when you're getting to know somebody, right? Our culture is that you're just getting to know your clients and you're inputting the information into the system. So if you call it compliance, it completely changes that part of our culture that we're trying to develop. So we call it alignment. These are aligned with what you know about your clients, and that's the way that we view it. So in our original dashboard, in we use CRMS, we had a 54% alignment rate. So we knew there was work to do. And the training that I talk about, we developed that training in order to improve that rate and evaluate our process. And after the training that we implemented, that alignment rate increased to 91.6% within 6 months of delivering the training to people. So that's a way in which you evaluate your process as you're doing it, right? I evaluate whether or not training and taking that way of doing things was effective. So we saw the effectiveness of actually providing opportunity and training for staff to talk about their hesitancy with asking questions or the reasons why there wasn't alignment. And then we saw that improvement go up. So that's our original dashboard. And this is our current dashboard. So when PDS came in and we moved from CDS to PDS, you see there's way more information in PDS than we have in CDS. So we changed our dashboard, and we also then changed our training to navigate the actual breadth of questions and demographic information that we are now collecting. We were well on our way, and I think we recognized that we had built capacity within the staff and within the organization to have a very different perspective around data. In building our data equity culture, that training went a far way. So when we moved to PDS, it really was just additions, right? We were adding more information. And then we sort of added that part of it to the training as well. The idea that, this is a lot more information, so it may take more time, but it is still the social determinants of health. This is what we're doing it for. This is the why still. All of those things still pertain. It's just there's more information, and we are getting deeper into an understanding about the intersections of people. So this is where in our training now we talk about the intersectionality piece. This idea that the more information that we have, the more complex we recognize that people are, and their intersections matter. So this is our current dashboard. And then I'm going to do a live demo for you. Give me 1 second. And then I'm going to need someone to let me know if you're seeing my screen.
Yes, we are.
Awesome. Thank you. So this is our dashboard. It is live. It is active. It's updated every evening, every night. So this is current as of today, right now, information at SHIP. So the first page of our dashboard is, and you'll see our alignment rate went down. We were at the 91.6% after having done all that work with CDS, but it certainly went down when we added PDS and when we changed it, simply because folks had to now review and go back to their clients and talk about more things and get to know other things about clients. And that takes time to build. So the idea that we have been talking about, that we're getting to know clients, so there's no timeline on that, exists. And you're seeing that in the 79% alignment rate. And we are in the process of retraining all of our staff on the PDS dashboard as it's changed. So this dashboard is our alignment rate, and it is all of those areas of PDS that you see here. We can view, this is the whole organization. So this is all of SHIP. You can also select by program. All of the programs are here on the right. So you can select by program, and this is what our program managers do, is that they have access to this dashboard and are able to select their program and see their alignment rates for their program itself. I tend to stay on this page where it's the whole overall organization to kind of get an idea of what we need to do with our training programs. The second page I won't show because it does have identifying information of staff, but I'll let you know what it is. So in the second page of this dashboard, you can search by staff, and program managers can take the, can search by staff and sit with staff and show them their alignment rates for each client. So each client, each staff's caseload will come up, and the clients, as well as their alignment rates for each of these areas. And so what program managers can do in their one-to-ones with staff or supervisions is really have conversations. If there's an alignment for particular clients, what does that mean? Like, why? You know, and have those conversations. Is there some uncomfortability, some hesitancy? Is it a client thing? Like, is there hesitancy from the clients? And have conversations about that so that they can then support them to figure out how do we work on this. And the alignment, I will say, is that and most of you who collect PDS do know as well that with PDS, there is a section, like there's an option for all of the questions that was asked but declined, right? So the client always has the right to decline to answer a question. But in our training, we talk a lot about the idea that it is about the offer. So asking makes, well, they say ask but decline, that's the option, but we say it's about the offer. So if you've made the offer and the client has declined to answer it, and you've put that into CRMS as the answer, it will still be aligned because that's aligned. That means that you've made the offer, you've answered the question. The client has declined, that's the answer to one of these areas. So as long as the offer has been made and you have had a client decline, and that's what you put into CRMS, it would still be aligned, right? So our 21% that we have left to go for alignment, it's questions that have not been asked. It's things that haven't been asked or answered yet, okay? And then I'll go to the third page because that's the most interesting for me and for many of us. This is who we are, and this is how we view this at SHIP. This is who we are as an organization because this is who we serve. These are the people that we serve. These are the answers to all those questions, and we're able to go into each of these. And what you'll see is that when I go into ethnicity, we have an unalignment rate of 9.13%. And I'm just thinking if I can make it bigger so y'all can see. Let me try to make it a little bit bigger. So if I go into ethnicity, you'll see we have an unalignment rate of 9.13%. So that's pretty valid. That's pretty valid data and information. If you click into any of these, what you will see is the dashboard will change. And so I clicked into ethnicity of Black Caribbean, which we have 13.23% of the clients identify as Black Caribbean. And then when I clicked into it, it changed all of these. So what I'm able to now see is that 13.23% of Black Caribbean clients, also 25.5% of them identify as Christian. 37.21% were born in Canada. And then we have the gender identity 44.19% identify as male. So when you click into each of these areas, each of these answers, it then changes the dashboard to give you the equivalency across. So you're able to see and search by any of these items, any of these questions. And then you're also able to search by program. So what this does is it gives us an opportunity to really intentionally look at who we serve, the populations, the groups, and then we can also search by location. Because we serve such a broad region, such broad regions, we can also see who we serve in Peel, who we serve in Mississauga, who we serve in Dufferin, and what did those demographics look like. So the opportunity to really profoundly use data to build equity into practice is there when you have information like this. But what's more important is that it was collected in a way that is equitable also. That process that we have developed at SHIP provides opportunity for people to share their information with us. And Madeline, if you want to bring it back up, that would be fantastic. Thank you. So the process that we've created goes alongside with this dashboard, and what we are able to do with our dashboard and the information that we have on that dashboard speaks then to the processes that we create as a result, the programming, the services, the access points to service. So we are able to use our data to evaluate whether or not our programs are effective for particular populations, for particular groups, and whether or not our access points are effective for particular populations and groups. Next poll. So how do you collect other data outside of demographic data? So we just went through what we collect, how we collect demographic data at SHIP. And then the second part of this is, do you collect data for both staff and clients within your organization? Awesome. So a lot of people are collecting more than just demographic data, which is fantastic to see. And you'll have an opportunity in a little bit to show us all what other types of data you're collecting in just a little bit, but that's fantastic to see that the majority of us are collecting more than just sociodemographic. Not to say that sociodemographic data is not important. I think we've established that so far, that it is very important data, and what it can do, what that information can do to help you build equity into your practices and know yourselves as an organization is very important. But other data is also important as well. And that's why we asked this question, because there's opportunity here for us to go beyond the demographics, to use the demographics and expand on what the demographics tell us in order to become a much more equitable organization. So we all know the qualitative and quantitative information and data that we're all collecting. Both are important to provide context. Quantitative certainly gives you, an idea of the breadth of services that you're providing and who and where people are and how many people in certain areas you're providing services to. But the qualitative data, and like I said before, with our dashboard, we've linked the two together, right? It's a way of evaluating whether or not our processes are effective. And we can use our quantitative data approaches to build qualitative evaluation processes as well. We have staff and client focused data, so we'll talk a little bit about the staff stuff in a second. We have health equity data, and I'm going to take you all through very quickly. We do a whole training on health equity, so I will take you all through very quickly our health equity process at SHIP. It's very, very important data for us at SHIP. It's what we build all our health equity plans around, is collection of health equity data. And then, we're all familiar with the social determinants of health, but we've also factored in the structural determinants of which we are a part. The structural determinants, for those that may not be as familiar, are really around the systems that impact people and that determine health outcomes, education outcomes, quality of life outcomes. So we also recognize that in order to our improving equity within our organization also means that we improve the systems and that we have to have an impact on the systems that our organization belongs to. We do belonging data collection around belonging for our staff and our clients. And we collect data around reconciliation, and if when I did the land acknowledgement, I referenced the 94 calls to action extensively in the land acknowledgement. And we have a reconciliation plan that we collect information about. It is Indigenous led and driven by Indigenous staff within the organization. And we have made commitments to the 4 for health, the 94 calls to action, the health calls to action that we evaluate and that we collect information about. And certainly we collect information around intersectionality, which I tried to attempt to show you with our dashboard, how you can really look at intersections when you collect that much type of information. Okay. So as promised, and I'll quickly take you through our health equity data, but like I said, this is it's a focus for us at SHIP because health equity, we are a health service provider. And so health equity and the HIA, we use the HIA, the Health Equity Impact Assessment, which we have used for years within the organization to develop our health equity plans for our programs. Okay, so another video just quickly to get us started on what health equity is.
Better understand the goal of health equity, you need to learn what causes health differences among groups of people. Health inequities are differences in health that are avoidable, unfair, and unjust. Social, economic, and environmental conditions can affect health in a number of ways, creating health inequities. Social inequities occur when a person is treated unfairly because of things like race, class, gender, sexual orientation, or immigration status. Institutions, such as corporations or schools, have the power to create unequal opportunities based on social status. These unequal opportunities can lead to poor educational outcomes or fewer job opportunities, creating economic disadvantage. For example, a college graduate earns over $36,000 more per year than someone who did not finish high school. Income can determine the neighborhood you live in. The environmental conditions of a neighborhood can affect a person's health. In Marin, California, someone can live 15 years longer than someone who lives just 8 miles away. Why? Lower income neighborhoods tend to be in poor social and environmental conditions. Examples include being closer to environmental hazards, such as freeways or power plants, having higher crime or violence rates, or limited access to healthy foods and safe places to exercise. Social, economic, and environmental conditions can affect health disparities, which are differences in health among groups of people. Health behaviors affect disparities. If people are not educated on how to lead a healthy lifestyle, or they lack social and financial support to make healthy choices, they may choose certain behaviors over others. Behaviors such as smoking, poor nutrition, or unsafe sexual behaviors increase chances of developing chronic conditions or diseases, which can affect how long someone lives. Smokers live at least 10 years less than non-smokers. Health disparities are also affected by genetics. We are learning more every day about how our genetic makeup makes us more vulnerable to certain health problems. Access to quality healthcare is one key in reducing inequities and disparities, but health is more than just disease or illness. Health is how we treat others, the opportunities we are given, where we live, and our everyday behaviors. Nobody should be denied a chance to live a long, healthy life because of social, economic, or environmental conditions. To achieve health equity, we need to eliminate avoidable health inequities and health disparities. We need to create fair opportunities for health, provide equal access to resources, and invest in low-income neighborhoods. Health equity will be achieved when everyone is able to reach their full health potential.
So the reason I start with that video, similar to the equity video, is that I think it's important that we establish a common understanding of the importance of health equity. We're, for the most part, many of us are health service providers here. And so our outcomes that we are hoping to achieve with our clients and with the community are health outcomes. And so when you anchor that back to the idea that the services that we are providing are the social determinants of health, we are all the social determinants of health. That is what we impact the most as service providers. And I'm just trying to advance it and it won't go. I don't know if I don't have access anymore. Oh, there. Thank you, Madeline. We're health service providers or a service provider of some sort, a social service provider. You are the social determinants of health. That is our impact. That is what we impact the most. So it then follows that we need to have a perspective around health equity. How do we impact folks equitably? How do we evaluate whether or not we're doing that? The HIA is one tool that folks can use. There are other tools out there. I'm just sharing with you the one that SHIP has used predominantly over the past 17 years since I've been in the organization. And we have a few different things that have come from our use of the HIA that I'll also share. The HIA, or Health Equity Impact Assessment, it helps us to align our services, policies, and programs with need that we identify, enabling better health outcomes. It's a structured method that enables you to include equity in health planning and decision-making. It's a practical tool because it's an assessment tool. It helps us to anticipate and address any unintended health impacts that our policies, our programs might be having on vulnerable or marginalized groups within the general population of the clients that you serve. It builds on existing work and creates greater transparency and consistency in the way that equity is being considered across our health systems. And the end goal of the HIA is to achieve health equity and eliminate the disparities that exist within your organization or within the health system. So this is what the template for the HIA looks like, and this was available on Ontario's website. I don't know if it still is because they are going through some transitions and they're likely going to be adopting another tool as their main sort of tool that they make available to folks. But we have used the HIA for so long, and we have effectively used the HIA because we have evaluated our use of the HIA. So we will likely continue to also use the HIA as well as the other tools that are being developed. But what we have done is we have taken this template and we have adapted it to meet our needs as an organization. So although we still practice it and we use the tool and the way it was intended, we've adapted this template to better meet SHIP's needs. And what we generate from the HIA, so I have a team of HIA facilitators that we have trained to facilitate, and they are staff from the organization that have undergone our training that I provide, and that once they are trained to facilitate the HIA, we do the HIA with all of our programs in the organization. And what we are looking for when we do the HIA is unintended impacts that are happening. And then you move those unintended impacts to a strategy. And so every program will come up with what are the unintended impacts and what is your strategy to reduce the unintended impacts and improve the unintended positive impacts. And that strategy then becomes the Health Equity Action Plan for that program. When we look at all of the action plans for each program, what I do is I pull out the themes, the common unintended impacts and strategies across the organization, and those then become the organizational health equity plan. What are the common experiences and impacts that we are having across multiple populations within the organization, across multiple programs within the organization? And I have pulled out for this year, we've done the HIAs with all of our programs. And this year we have seen 4 common impacts and strategies across, and we have congregate locations, we have community programs, we have residential programs, we have just service-based programs, and we've done it with all of them. And so we still see these 4 common strategies and common impacts that then become the organizational plan. And that's what we're evaluating as an organization. So each program has their health equity plan because they want to have an impact and eliminate inequities within their program for the clients that they serve. But then as an organization, we want to have that overall health equity impact. And we want to be able to evaluate what that impact is and whether or not we are actually having an impact and eliminating inequities. So that's the way in which a tool like the health equity impact assessment, combined with an equitable approach to sociodemographic data and data collection, can help you to build action plans that are based in equity. So we've done a lot with our health equity program at SHIP, made a lot of changes as a result of doing the health equity impact assessment and having health equity plans for the organization. So we've developed partnerships as a result, where we were seeing that there's inequity in the way we deliver our services due to language barriers that exist for clients that we were not trying to change. So we have developed partnerships on purpose in order to eliminate that barrier. We also never had a process around service dogs or therapeutic animals within our congregate locations that were identified through the HIA, and we were able to develop a process and a policy for that as well. And then we also developed a health equity charter as a result of having done the HIA for so long and having had health equity plans and outcomes for such a long period of time that we're able to sort of see progress and do comparative analysis of our health equity outcomes over the years. We've been able to develop a health equity charter. Won't move. Okay. So that was a focus on health equity because that is one of the focuses, like I said, for SHIP. As an organization, we're a health service provider, so we lean heavily into health equity. But certainly one of our priorities in the organization is building a data equity culture. And we have developed some tools that I'd like to share with you just briefly in order to help us to do that. So the first thing that I want to share with you is our equity assessment tool. This tool is a labor of love for many of us on our EDI committee. We took a long time doing the research around whether or not there were tools available that would help you to assess your policies, your processes, your programs, groups, using an equity lens. We all speak this language, and after 2020, everybody started talking about an equity lens and doing this with an equity lens. But we asked ourselves, what does that actually mean? What is an equity lens? And what does that look like when you're saying, evaluate this with an equity lens? And so we developed a tool. We researched what tools were available or how people assess with an equity lens. And we didn't find anything. We found a lot of information, but we didn't find a tool that we felt would work for us. So we created our own based on all of the research that we had done, and we pulled from many different sources. But our EDI committee worked together to create our equity assessment tool that is now embedded in our process. So one of the things that we're able to do now is to use this equity assessment tool and have made it required that anytime we have a new policy being developed or process, or a current policy or process being reviewed, they must come to EDI to do an equity assessment on. And then we use this tool and we provide recommendations based on using this tool that we developed. The tool really is, it walks you through impact. It looks at impact. Who is impacted by your policy, process, or procedure, or group that you're developing for a program? Who's impacted and what that impact looks like, and whether or not you've spoken to that within the policy itself. It's actually 3 or 4 pages that walks you through who you've consulted, Have you had the people at the table most impacted to develop this policy or process with you from the beginning? And if you haven't, then you should be consulting those folks. So that's our equity assessment tool, which is one way that we have developed tools to help us build equity into our culture. And when you look at the types of data that you need to collect in order to build a policy that is reflective of everyone, most people don't even think about that. You start writing a policy, you think you kind of know what it should be about and who it's going to impact, but this tool sort of points you in the direction of collecting the data, the evidence to support what your policy is saying. The second thing that I'm going to share with you all is that, we talked about staff and client data being equally as important. The people delivering the services to the clients in an equitable way need to also be treated equitably in order to model how to deliver equitable services. So one of the things that we developed was a belonging survey. And we collect information from staff all the time, but we do it in very different ways. This survey we did through Menti at a staff day, and people certainly had the option to participate or not, but we did have quite a bit of participation. And we developed these questions through our ERGs. So we have employee resource groups that are reflective of the staff body. So for example, we have a BIPOC caucus, Black Indigenous people of color. We have a proud ERG for 2S LGBTQ plus folks. We have an ERG abilities, so folks with disabilities or accessibility issues. We have an ERG for the environment, so Enviro ERGs. So we have several ERGs that came together to develop these questions around belonging. And do staff have a sense of belonging at work? Are they able to bring their authentic selves? What are the barriers that they experience? So this is just another way of surveying staff, collecting data in a different way that is also developed by staff for staff. So one of our mottos at SHIP is for people by people. And it's certainly voluntarily if they want to participate and engage or not. But we have found that people, when you provide space and opportunity, are more than willing to participate. And then finally, I'll end with this one. Our ABR survey, so our anti-Black racism survey, is something that we participated in that was through the Mississauga OHT. They offered to organizations within their OHT, and I believe West Toronto as well, a self-assessment to staff members in the OHT that could help identify the current state, capacity, and opportunities to meaningfully address anti-Black racism. We participated in that survey. The Institute of Better Health, which was the third party that collected and analyzed and reported the results and shared back the results with participating organizations. We had 98 people at SHIP complete the survey, and we used those results that we received back disaggregated from IBH to identify quality improvement efforts to meaningfully address ABR in our organization. And what we did is we developed an action plan through like I said, we have a BIPOC caucus ERG that then reviewed the survey results, bucketed them into priorities. We looked for overarching themes, and if the action was directed at client, staff, or overall as an organization. We developed an action plan and a commitment statement that we transparently shared with the organization. And we prepared a draft plan that articulated the priority areas, actions, timelines, responsibilities, and metrics. But how we prepared that plan is the important piece. We consulted. We created safe spaces for Black staff within the organization that were facilitated by Black staff within the organization to review the action plan, provide their feedback, and to make any amendments or changes that they think were not reflective of their experience at SHIP. We had both virtual and in-person sessions for those that were comfortable. We intentionally created safety. We have a safe spaces program at SHIP as well, where we train folks and we offer safe spaces on a monthly basis in the organization. So folks are very familiar with the idea of safe spaces and brave spaces, but this was intentional. There was intention behind what we were doing and how we knew we needed to do it and by building equity into the actual practice. The idea that safe spaces for Black staff were run by Black staff, that we provided spaces that we knew were safe, both virtually and in person. And we're very intentional about that. And that I think was very successful. That was the reason why we were so successful in getting the feedback that we did and having the recommendations that they made towards our anti-Black racism action plan within the organization that is reflective of the people most impacted by that plan and by our policies. So that is just an example of how you can take data, because the survey itself is the data. The survey told us things. That was our data collection. That was by a third party that people felt able to do it because it was a third party disaggregated data. And then we took that data and we included the community most impacted in the process of evaluating that data and information and in the process of developing any plans from that data. So just an example. Okay, I'm going to turn it over to Laura for our last poll.
Yes, so we wanted to have another engagement activity with participants, and we are wanting you to use the annotation feature within the slide presentation. And so you'll note that there is an icon in the bottom left-hand corner of the shared screen. So we want you to click on that and you will see a vertical toolbar pop up on the left-hand side of your screen. And that toolbar will allow you to type text into the screen on our next screen where we have our activity planned. So I just wanted to familiarize yourselves with that toolbar. And then the other tool that we wanted you to, or feature we wanted you to pay attention to, is that blue X. It actually should be a checkbox actually on your screen, but it'll allow you to use like a stamp, it's what it's called. So hearts and stars. So if you're seeing somebody else typing on there and that you like what they've typed, just emphasize that with the stamp. And then the other piece that we wanted to share as well is that if you're typing in your text, you have to click off of the square in order for that to show up on the screen for others. So we'll move to that activity now. And Shireen, did you want to kind of
Sure.
lead us into that?
Absolutely. So our final poll is more of a brainstorming with you. What other data equity measures are you taking to develop a data equity culture? So it could be things that I've already mentioned or things that you're doing that contribute to building equity into your use of data or your analysis of data that I haven't mentioned. Would love to see what folks are doing within our systems to create data equity cultures. So take a stab and see if, oh, look, first one, excellent. So patient experience survey, thank you. Client satisfaction surveys, yes, absolutely. Staff experience survey, absolutely. Those are all very important. We've got a bunch of stamps. Look, everybody's enjoying the stamping feature, I think. So that's a win. Yes, absolutely. Takes a little getting used to. I had to learn how to do this too. I wasn't too sure myself how to do this. Patient reported outcomes, fantastic. Any others? Awesome. So a lot of check marks, a lot of folks are doing these patient or client satisfaction surveys, experience surveys, accessibility to resources for remote communities. Mm-hmm. Awesome. Systems that provide data outcome measures, training and awareness sessions. Oh, it's just popping all up now. Fabulous. A lot of really amazing things are happening, inviting conversation instead of I don't know what that's supposed to be. I don't know if Laura might know.
Yeah, I'm not sure. I was going to say blank instead of blank.
Partner satisfaction score. Oh, that's very interesting. We're looking at doing something like that as well. Very, very cool. Okay, I see the time is moving, but I want to
Yes.
thank you for participating in this. So what I will say, when I look at this, and hopefully when you look at this, what we see is the system approach. And I'm going to take us right back to the very beginning when we talked about justice. This is our roadway to justice. This is our roadmap to justice. This is the voice of the system. What you are all doing to create equity, to build data equity cultures, all of these things that you've put onto this slide show us the way to create a system that is just, to create just culture within our system. So when we talked about at the very beginning, how do we move? Equity is the work. Equity is the work that we're doing. This is the work that you are doing. Imagine if you added one more step. If you added one thing here that you're not doing in your organization, but you see it there, like I said, the partner satisfaction surveys, we're not doing that. It's a great idea. Maybe it's something I can add to our equity culture at SHIP. If we all added one more thing from here, so take a screenshot of this poll, of this page, and add one thing. That's my challenge. Add one thing, one more step that you're not doing. We will create a just culture for folks. We will create justice within our systems. Okay. Thank you. And I think there's a poll up now.
Yes, and we're just asking folks before they head off if they could just complete that poll while you take us through your takeaways, please.
Awesome. So finally, takeaways, hopefully, that you got from the presentation. Ensuring representations at the table for decision-making around any changes from an informed approach. Build in the client and staff voice wherever possible. Develop and build sound data collection processes. And if you don't have them already, if you don't have a frame of reference, create them yourselves. You have the power. You know, data is power. And I was going to make a cheesy reference, but I'll do it now because I didn't do it before. But data is power. And, you know, to quote Uncle Ben from Spider-Man, with great power comes great responsibility. And that is what we are doing here as organizations. We understand the power that we hold because of the data that we collect. And so we really have to take the responsibility. We want to refer to our data to ensure changes are evidence-based. Take your time, build foundation, use inclusive tools, and remember that our equitable approaches require intentional, meaningful action informed by those most impacted. So I know we went right to time and I apologize for going so long, but I want to thank you all for allowing me the opportunity to speak with you and share some of the things that we're doing at SHIP today.
Thank you so much, Shireen. I do want to encourage folks to continue to answer the poll questions for our final poll for today. We really appreciate your engagement in all of the previous polls. We do have a couple of questions, Shireen, and I'm not sure how much time will take you to answer them, but we'll start with the first one, which was the first two questions were related to your dashboard. And we had a question related, or a question was, what is the data source for alignment versus unalignment? And then the other question related to your dashboard is, were the questions asked verbally, both pre and post?
So for the alignment and unalignment, we use CRMS. So the client record management system is our data management system. And when our staff put the information into CRMS, the dashboard pulls directly from CRMS. So unalignment means that the questions are not answered. So there's nothing in CRMS. If they tick off, like I was saying, the asked but declined is one of the options. If they tick that off because they have asked the question or they talked to the client, but the client has declined to answer, it will be aligned. It will say it's aligned. The only unalignment is when it's blank and not answered at all, and so in CRMS, it shows up as red. If there's a red box and it's not green, that is what is counted as unaligned in the dashboard. And then the second part again, Laura?
Pre and post verbally, was it asked verbally, pre and post?
So all of the questions that you see there for the PDS are interactions with staff. So staff can do those questions or ask those, have those conversations however they choose to, whatever they feel is most comfortable for the client. At the intake point, when we're asking those questions at intake, or when the intake workers are going through the demographics with clients, much of that information is on our application. So the application will provide as much as a client completes. And then once we have that, if there are any gaps, that's what the conversation from the intake staff will be with the client. Just the information that isn't there if the client is, or if the applicant is comfortable enough to tell us verbally, we do have those conversations in a follow-up to the application. Hopefully that answers it.
Yeah, that's great. Thank you so much. Just a huge thank you to you, Shireen, for taking time to prepare and share your knowledge and wisdom. I love all the practical examples that you provided for us today. I do recognize that we are just past our 2:30 time, but I will close out the session now. We do have some final slides within the deck that we encourage folks to take a peek at, specifically part 2, which is happening February the 18th at 10 a.m. and the registration link is in there. And would love to see everybody join us again, where Shireen and Alan from Services and Housing in the Province will share some more of their wisdom with us. We also have these fine folks coming to share with us again at our community of practice in February. And so more to come on that. And please do not hesitate to reach out to us. We're happy to hear from everyone.